Hey, everybody. Thanks for joining us today for Data-Driven Analytics, Optimizing Patient Access. This is the first part in a six-part webinar series on data-driven analytics. My name is Scott Everett. I'm the Vice President of Healthcare Solutions. And joining me today is our Client Success Manager, Greg Giudice. Welcome, Greg.
Thank you very much. Happy to be here.
So this is going to be interesting because, Greg, in a former life, you were a physical therapist, and it'll be good to talk about patient access from a clinician standpoint.
That's right. So about 10 years as a physical therapist, half of which I ran my own practice. So got lots of clinical, operational, and now some data experience. So I'm excited to be here and share what I know.
Great.
So for those of you who do not know us, PDS is a healthcare analytics company. We help our customers gain insight using data and help them to drive change. PDS provides best practice data modeling and staging to meet your healthcare organization's unique analytics and reporting needs.
And like I said before, this is the first webinar in a series of webinars we'll be doing over the next 3 months on data-driven analytics. And, you know, it's interesting, Greg, I was listening to a coach the other day, and this coach a couple years ago, if I'm being honest, was probably right on the verge of being fired. But in the span of about 2 years, they went from perennial losing seasons to contending for conference championships and being ranked in the top 25 nationally. And someone asked the coach, what was it that turned you around? And the answer was fairly simple, was just we turned to the analytics. And what we want to do with this webinar series is help those of you out there who are running practices to turn to the analytics and find similar success, whether it's in denials and recovery, whether it's in HCCs or physician compensation. We'd love to have you join us for any or all of these future webinars coming up, and hopefully we can help you to find similar success.
Absolutely. So part of what we want to talk about today is, what does it really mean to be data-driven? How do we apply these data-driven principles to patient access? How do we increase the analytical intensity within our organization? How do we use data to achieve the solutions that we want to within our organization? How do we evaluate the effectiveness of the changes that we've made? So being a data-driven organization is the continuous use of data to uncover opportunities and improve performance. We need to eliminate those personal biases and make decisions based on what the data tells us, rather than just making assumptions.
Yeah, so a lot of organizations, you hear the term data-driven all over the place now. You can't sit through a conference presentation without that term being brought up, but it's difficult to actually get there. And there are some roadblocks that organizations really do have to overcome, most of which involve resources. Being data-driven really does involve staff. It requires training, it requires expertise, it requires budget, and it requires some technology to be put into place. And that can be difficult when there's a lot of competing priorities from a technology standpoint. Even then, sometimes there are restrictions on the types and availability of data within your systems that the vendor allows you to receive. And so these things can all lead to, you know, difficulty with a data-driven culture, but a culture is really what we're looking for. The biggest roadblock that we find a lot of times is just leadership, not necessarily wanting to get to where they need to be in order to be truly data-driven.
Definitely, yeah. So data-driven organizations take the time, take the money to invest in their analytics and make sure that their users can use the data efficiently. With the data, the users can utilize the information daily, find those performance gaps, and continually improve upon the gaps. Capturing the data and using it effectively becomes a part of the culture, just like you mentioned, Scott. And if it becomes part of the organization, then we're all winning.
Right. And, you know, I look at this, and what we're really trying to do is, you know, balance perspectives that are out there. We're trying to say, you know, the physicians have one perspective, leadership has another perspective, and really turning to the data to see what's actually going on within the practice is what's critical. And that's what you utilize in order to move forward. And we want to take this webinar and let's apply this specifically to patient access. And for this webinar series, we wanted to start with patient access because we found that it's a huge competitive factor within healthcare right now. I saw a survey the other day that said only about 53% of patients, just over half, really consider loyalty to a provider as a factor when they're choosing where they get their care. So not very many people are saying, Dr. Smith is my doctor. I need to go to my doctor. As patients are being tasked to shoulder a lot more of the burden of the cost of healthcare, what they're really doing is they're finding they would prefer to have timely access, convenient access. They want to know the costs and they want to have it be affordable. And so these are the things that are the leading factors in choosing where they get their care. And what's going on is a lot more competitive options are arising for these patients.
That's exactly right. Especially here in St. Louis, and I'm sure every community around the country, there are just tons and tons and tons of options. There's a clinic on every corner and an urgent care in every shopping center. So how do we use data to stay competitive? And if we can do that, that's how we stay ahead of the competition.
So we have a lot of people who will come up to us at conferences or whatever and say, you know, we're having trouble with patient access. Do you have any advice? And I always say, you know what, I really would need to see the data first, because there's a lot of different things that can go into it. The biggest issue that we find right now is that when people say they have a patient access problem, this is what they think is going on. They are at full capacity. They are filling every appointment slot. Every patient is showing up. They have no room to fit anybody else in anywhere else. And so if I saw something like this, just looking at visit counts by session and seeing that it's a level line, if I looked at the data and saw this, I'd be like, yeah, you're right. There's the only thing you can do from this standpoint to increase capacity is increase resources. You may need to bring on new providers. You may need to look at additional clinical space. You may need to open a new clinic, something to do that. The problem that you have, though, it never looks like this. This is not reality. What it always looks like is something like this. Okay, where if we simply look at session times, day of the week, time of the day, we know what we can do. We just look at the highest one and say, you know, we know we can do this because we are doing this. But every section that you see here that's in purple, there's available capacity during those times. The trick is digging into the data to determine why is this capacity available and what do we need to do in order to be able to fill it.
Right. So when we start to evaluate capacity, we have to look at these three things: people, process, and technology. That includes how long each clinician spends with each patient. That includes call center data and staffing concerns. That includes cycle times, including the time spent in the waiting room, time spent in the exam room, as well as the total time that the patient spends in the facility.
Yeah, and you talked about technology as well. As I've worked with various systems that do scheduling. Each one's a little bit different, and sometimes it can be a little tricky to optimize a provider's template out there. There are some things that they may not even know that they're doing until you dig into the template. The utilization of frozen slots or held slots, the difference between a frame rate and a slot duration and an appointment duration. There are some inefficiencies built in there sometimes that you can find where there's some availability, but you really have to know what you're looking for, and you have to really dig in and find those. So really what it takes is going much further beyond what we showed before with, you know, we have available capacity, but why is it available? So we could start by maybe getting a little bit more granular. Instead of looking at individual sessions, we can look, you know, down at the hour level, and we can see what is scheduled, what's available. We can look at what's held for urgent care, same day appointments, what's being held for telehealth, and then what's just frozen or held for some other reason, whether it's administrative time, academic time, whatever it is. We could dig in and we could see what's there and what's going on. And if it doesn't look right, that's when we can start looking, you know, individually. But even this type of fixed visualization is really limiting. I would like to be able to dig in and look at a provider level. So let's take a look at a visualization here where this is provider level, and it can be interactive. A lot of the tools out there can give you the ability to set filters and things like that. But you can see right away, I start with this day of the week analysis, Greg, like we talked about before. And I could see, okay, here's my available capacity. What are we missing with these visit counts here? I can dig in, I can look at third next available. I can look at the percentage of the provider's schedule that's booked versus available. I can look at appointment lags, and I can see what's being booked same day or within 3 days, what's being booked more than 3 weeks out, and really dig in that way. And so all of these can help us to identify things that are going on within scheduling. But I don't know, Greg, when you look at something like this, what's the first thing that stands out to you as a clinician?
Yeah, the first thing that stands out is the arrival rate for the clinician Lois Pierce. Around a 50% arrival rate would be devastating in a clinic that I've worked at. That's just a really low number. So if that were my clinic and we notice that there's a time block that has a higher likelihood of cancellations and no-shows, maybe we can take that opportunity to double book that time slot as appropriate to maintain volume. Maybe we notice that there's a certain client or list of clients that have the same type of thing where they're more likely to no-show or cancel. And same way, you can double book those folks as well, just to make sure that you're maintaining your volume in the clinic.
Yeah, I agree with that. Appointment status. That's really one of the first things that you want to look at when you're looking into patient access is, what is your rate of what I like to call lost appointments? And what I consider to be lost appointments are no-shows as well as same-day cancellations. And so we could look at another visualization and we could see trends over time of something like lost appointments, and we can break it down. Again, maybe looking at, day of the week, time of the day, like we did with our sessions, and we can start looking at probabilities of these lost appointments occurring. And we can see here that Mondays we have a lot of available opportunity to double book those times, because we're at a little over 15% in our lost appointment ratios in between our AM and our PM. And so, that's just one way that you can look at. You can look at, different simple to use metrics. So a dashboard like this is something that I could get from virtually any system that's out there, because you're just looking at simple scheduling metrics that are out there. And this lost appointment ratio is a good place to begin. When you look at lost appointment ratios, we could look at the second page of this dashboard, and you can also realize that one of the things that really leads into higher probabilities for lost appointments is your scheduling lag, where if you look at your cancellation rates or your lost appointment rates, you can see as it hits 30 days, actually as it hits 15 days or more, your probability of having lost appointments is really greater for those. So if you really want to get granular with your data, you can look at those high probability sessions, but in addition to that, look at the ones that have the highest appointment lags, and that's where you can really find opportunities that you're probably going to have a lost appointment to double book. You can also look at the appointment lags by appointment type, and you can start seeing, are there some inefficiencies in this, where I look at my physicals and say we're 110 days out. That doesn't bother me, because hopefully if we're doing it right, we're scheduling our physicals or wellness visits as they're leaving the last one. So if we have a 365 or more day lag on that's a good thing. Actually, it means we're being good and proactive with those. But when I look at follow-ups, when I look at new patient visits, established patient visits, and I see those being more than 2 weeks out, that could be problematic, and that could be a competitive problem that we need to look at and really try to dig in and understand as well.
Absolutely. So let's talk a little bit more about analytical intensity. So how is the data that you're using helping you achieve your goals? If we want to be a data-driven organization, how do we get to those higher levels of analytical intensity that allow us to make decisions that have a higher ROI. So as Scott mentioned, the lower levels of analytical intensity are summarization and trends. And we've looked at a lot of those dashboards so far in this presentation. Information like total patients seen per month or total revenue. And then comparing those numbers on a monthly or quarterly basis can help see trends with how the practice is progressing compared to the previous period. Things get a little bit tougher when it comes to benchmarking or comparing ourselves to the internal goals or industry standard metrics. It's even more complex as we get into projecting outcomes based on a proposed behavior change or even a new payer contract. And we'll talk more about these things later. So Scott, most practices are doing summarization and trends, which is fantastic. But let's talk a little bit more about benchmarking.
Yeah, so benchmarking is a good way to start providing context to these metrics. One of the things that I've noticed as we engage with clients in, really any sort of data project is they start seeing the data coming through from their organization and they start saying, is this good or is this bad? And where should we be? And, my answer to that, to where should we be, is you want to be better than you were a year ago. You want to be better than you were a month ago. You want to be better than you were a quarter ago. Just really start comparing yourself to yourself and strive for improvement. But really, if we want to be a high-performing organization, we need to start looking at the industry as a whole. And so let's take a look at a visualization here. This is just kind of another fixed visualization that's fairly simple. And again, just some fairly simple, easy to measure metrics that are out there can really be helpful to provide context with where you're performing well or where you may be struggling a little bit. So if I look at a dashboard like this, I can see right away when we're looking at hours open per week, and I see we're open 34 hours per week, okay? Our goal as an organization is to be open 40 hours a week. We're falling short of that. But even then, I look and I see the industry's at 46 hours per week. That's something where I'm like, this is a big competitive disadvantage to us, because not only are we not as available as other competitors within the market, we're probably not at times that the patients want us to be open. And so I see something like that and I'm like, that's something that's got to change immediately. In addition to something like this, I can see, because of conditional formatting, I can see right away, our same day appointments, we're doing pretty well. Our number of appointments per physician, we're okay. We're meeting goal, but we're not at benchmark level yet. Third next available, we're not at our goal, but we're about where the industry benchmark is. So we can see right away, I can digest this. I don't have to spend a lot of time pouring through a lot of information. It's all right here in front of me. And so this is a nice thing to look at. But, if we want to take it to the next level, a visualization like this is great. But a lot of times visualizations ask as many questions as they answer. And so we need to be able to utilize our analytics to dig down a little bit further.
That's right. A visual is just one of the three big components of analytics. Most practices are using one of the tools on your screen here: Power BI, Tableau, Click, Business Objects, Cognos, Excel. They have these tools, but unfortunately, to hit these three components, they might be using three different software applications. And the problem with that is they can't query within the visualization tool. It can get time consuming to rewrite a query in every application that you have. Not everyone will have the skill or the time to do this in multiple tools. And this can even take power out of the user's hands, as they may need to ask for help, not knowing every tool in the organization. So knowing the three components of analytics is great, and having a tool for each is good. But Scott, what are the best organizations doing?
Yeah, so really what we're trying to strive for to be truly data-driven is a single source of truth. And like you said before, Greg, that, if you're using different tools for each of these, a lot of times if you want to go from one to the other, you have to write the report over again. And that can be difficult because you may be missing one of the parameters of the other report, or you may be missing a filter, or something happens that way. You want to really be able to move seamlessly from one to the other. So I want to go from my visualization into my slice and dice so that I can start trying to find outliers that are, leading to the numbers that we're seeing. And then I may even need to get into the detail, and it can be difficult and time consuming to move to that from something other than a single tool. And to illustrate this, let's open up another visual. So what you can see here is, again, a nice interactive visual where we can go in, we can apply filters easily. We can look at, different areas. But, what's interesting is if I'm an executive looking at this in my patient access and I go through, I can see right away, oh, I have providers that have a good deal of available capacity right here. Their schedule utilization is not full, some of them significantly underutilized. And I really want to understand why. So what I want to be able to do is look not just at those providers, but I probably want to be able to drill into that provider and really start looking more and more. And so this takes us into some sort of OLAP cube technology where we can apply filters, we can add additional dimensions. Really what we're trying to do is identify outliers. We can apply filters, and once we find a filter, we can go in and we can find something that really sticks out to us as, having a long lag or having a abnormally high or low appointment count for a specific time. And then once we have that, we may need to look at the individual detail level to see if it's one or two appointments that's driving that average in an area that we would want to see, or whether it's part of a recurring trend with all appointments, because each one requires a little bit different strategy in order to get in and correct. So this is what we talk about with, being able to seamlessly move between all of those. But let's go back to that top level visualization, because really as an executive or as a provider, this is really where we want to be spending most of our time. We don't want to spend a lot of time digesting data. We want to be taking this data and asking questions. And so when I look at something like this and I can see, the appointment status, I can see the day of the week analysis that we've always talked about. But sometimes I want to look at metrics that are correlating and really try to understand a little bit more. And so I look at something like third next available right here. Okay. Third next available is a point in time query where I say, okay, as of Sunday afternoon, if I tried to schedule an appointment, how long would it take to get to the third available appointment? Okay. Really, when I'm looking at the system, I'm asking what could happen. Okay. Well, my appointment lag is the difference between the date the appointment is scheduled and the day of the actual appointment. And so when I look at this visualization, what I'm seeing here is I have a lot of availability for my third next available in 0 to 3 days. Okay. My appointment lags are 8 to 14 days and up for the bulk of my appointments. So I could get in earlier, but we're not. That's not what's actually happening. And there's a disconnect there that we really need to understand why. Is it because our template is made it so that we have available slots from 4 a.m. to 6 a.m. and it's, really throwing off that third next available calculation? Is it because our patient demand isn't for when times that we have available? These are all things that, we want to take a look at when we see disconnects between metrics that should be correlating. So I don't know, Greg, as a clinician, what stands out to you?
Yeah, you mentioned the utilization per day, and that reminds me of in my clinic. Here in St. Louis, we live near a few different vacation lakes, and between Memorial Day and Labor Day, Fridays are hit and miss. We get a lot of low demand, high cancellation rates on those days. People, of course, looking to get a few extra hours of sun time, fun time. So what we did was we actually modified our hours to close at noon on Fridays on most weeks, and opened up an hour earlier Monday through Thursday, and we didn't have any problems at all filling those time slots. This led to higher revenue, lower cancellation rates, and this decision was just based off of trend data, so not terribly difficult to calculate. But we were willing to look at possible solutions, and this helped us really be successful. So, that can be very, very powerful.
Yeah, I'm sure it was one of your employees who wanted to go to these vacation lakes on Fridays that noticed
That
that
might have been
trend,
part of
wasn't
it.
it,
That might have
Greg?
been part of it.
Yeah. So anyway, that this information is good, and that's a great solution, is start looking at ways to meet patient demand for availability. With that as well. So let's look at cycle times. Cycle times is something that can help identify inefficiencies in your templates as well. And really what we're looking at in cycle times is the time the patients are spending in different areas within your clinic. So how much time is spent in the waiting room, how much time is spent in the exam room, how much time is actually with the provider. And depending upon the scheduling system that you use, some of these metrics are very readily available. You can get them just right out of the system. Other times they're not available at all, and you might need to break out a stopwatch and a clipboard and have your patients help you track this information. But really, this information, what we're trying to do is we're really trying to reconcile again what is happening between what we're saying in the schedule. So we're looking at the actual amount of time that the provider is spending with the patient versus the average duration of what was scheduled. Okay, are we meeting patient expectations that way? So we may have some providers who are scheduling very inefficiently because they spend a lot more time with the patients than the slot duration would indicate. We have providers on the other side who are scheduling a lot less time and not spending even as much time as the patient thought they had scheduled for. And so that can cause a patient satisfaction issue because they may not feel they're being listened to and things like that. So again, reconciling what should be happening with the system versus what is happening with each provider can help you find ways to really truly optimize the template of each provider and figure out how you can best and most efficiently set up those templates and find what and where your capacity actually exists.
That's right, and you can really see the impact of what's happening with those extremes of this provider schedule. Let's look at another dashboard here where we are going to see that impact by blending scheduling data along with revenue cycle data. Looking at the productivity, looking at patient experience metrics, we can see that lower productivity providers and lower scheduling stats might lead to lower patient stats as well. Having all of these data sets together in one visual can allow us to make more sense of the data as opposed to seeing 3 different reports in a tool like Excel.
Yeah, it's interesting that you brought in patient sat with this too, because, we talked before, Greg, about balancing the perspective between what the executives think is going on, what the providers think is going on, and what the data is actually showing us. There's another perspective we're missing here, and that's the patient perspective. And, even if we think we're doing a great job, even if the data is telling us we're doing a great job with our patient access, if the patients don't think we're doing a great job, we're not doing a great job. And so we need to make sure that we're balancing that. And if we're not reconciling again between what they're seeing and what the data is telling us, we really need to understand what's causing these patients to have the perspectives that they are. I think it's interesting that as we brought in some revenue cycle information on this as well, looking at the coding patterns of the providers, and people, well, why would you want to bring that in? Why is coding important here, Greg?
Oh, it's the most important thing. E&M coding is all time based, so scheduling is the main factor when it comes to measuring productivity.
Yeah, it's interesting. A lot of people, when they build the providers templates, they just kind of build it in, let's just throw in a slot here, an appointment here. A lot of them don't look at the provider's coding patterns to see how long do they usually spend with the patients. And even if you don't have cycle times, you can see it through E&M coding to help determine, efficient ways to set up these provider templates based upon how much time they're spending with their patients. And you can get that just from their E&M codes as well. So, this relationship analysis is that, 4th level of the analytical intensity that we talked about, Greg. But if we want to get to that highest level and start projecting out, looking at more predictive type analytics and how that can help us, what we really need to do to start is take a step back We need to start looking at benchmarking again. And the way we want to look at benchmarking, and the reason we want to look at benchmarking, is because we have to determine individually, and we actually have to determine this by each individual metric. Is it more appropriate for us to do internal benchmarking? Is it more appropriate for us to do external benchmarking? And so there are advantages to each of them. Internal benchmark, what we're talking about is comparing providers against each other within a specialty, within a clinic. It's really a complete peer-to-peer review where most of the parameters are equal. You're working with the same relative population. You're kind of on a level playing field that way. And so that can be helpful. And then again, with the metrics that you're looking at, when you're using internal benchmarks, you can be certain that the metrics are calculated the same way for everybody. External benchmarks, it's not necessarily so. You have to do it based upon the way that, you know, whoever's doing the benchmarking is calculating that information or that particular metric. But external benchmarking is when you really want to get to that highest level where you want to say, I'm not content being in the middle of the pack within our market. We want to be the provider of choice. We want to be the highest performing practice within our market, within our region. And so what we have to do is compare ourselves to other like-minded institutions and emulate what they're doing so that we can get up to that higher level. And so each one is, again, has its advantages, and each one is more appropriate and less appropriate. It has to be done at an individual metric level. And the reason we want to do that is because it's really the basis of our projections to find out where we are and understand what could happen if we were to move to a higher level of performance. And so let's look at a visualization on this. This is what we call our performance opportunity dashboards. And what we're looking at with these performance opportunity visuals is taking a metric like average clinic visits per session, or average revenue per visit, or average visits per month, any metric that we want to look at. And for this one, we're doing internal benchmarking, and we're comparing the providers against their division. Well, what we're projecting is if these providers that are performing below the division average, if they were to perform at the division average, there would be a financial benefit to that based upon the average revenue that they get per visit. So right now we can say if these providers were to perform at the division average, then we would see an average of almost $55,000 increase in revenue per physician that's below average in this area. Okay. We can look at it from the standpoint of, even our lowest 20% of providers, if they did it, they would go up to about $78,000 per provider. And the reason we want to attach this financial benefit is because if we really want to improve our performance, we're going to have to change the way that we do things. And so what we're looking at with performance opportunity is a very compelling argument to get people to buy into change. That we say, if you do it this way and take our recommendations, this is what's going to be the financial benefit of changing this behavior. And I don't know if you use something like this, Greg, within your clinic, or if you would think this was beneficial.
I've not used anything like this in my clinic, but man, I would have absolutely loved to have it. Just being able to see what would happen with a behavior change would have been really, really amazing. This can be especially impactful when compensation of the provider is tied to the productivity. Just seeing the numbers can make a huge difference in driving change with those people.
Yeah, and what's good about this is a lot of times the change doesn't have to be drastic. The change can be a fairly simple thing, like really digging into the templates and seeing, did we set it up the right way? Or if you could just increase a couple of visits per session or per day, that here's what could happen that way. And that prediction is really helpful, and it really leads to a significant return on the investment of time and effort that we're putting into this. When I look at opportunities like this as well, Greg, I start to think about ways that we can be more efficient? And, is it something we have to do across our entire patient base, or is there maybe something we can do with our patients who are coming in more frequently? Okay. Patients who may have chronic conditions, can we treat them a little bit differently? And could this benefit our organization? And I think really what we need to start looking at is understanding our populations. Okay. We can't really maximize what we're doing with appointments if we don't understand what our patients want, what our patients need, what are their demands. And we do have patients, I mean, I'm sure you had it too. You have your frequent flyers, right? The ones who are in multiple times per year and things like that. And so we really need to understand our population. We need to understand who are our patients at highest risk and who are the patients that we're treating for chronic conditions that we actually want to be the ones coming in more frequently. When we talk about this from a patient access standpoint, I know there's, patients who are in with chronic conditions, and what can we do to better accommodate their needs? And so, you look at someone who has a different condition. This is Bob. We talk about Bob a lot, particularly when we're talking about HCCs. So, Greg, meet Bob. We'll say for this particular example, Bob's a 78-year-old male, and in addition to having several chronic conditions, Bob just recently had a hip replacement. Okay, that's going to require physical therapy. He has these other conditions. Would you treat Bob a little bit differently in your practice?
Absolutely. These high risk folks are certainly a bit more complicated. They've got a more complicated medical history. They've got more comorbidities. Therefore, they require more time, more resources from the provider. Without data, our front office staff might not know what to do with these high risk patients and definitely don't know who they are. Maybe they get booked around the same time. This can leave us with fewer resources available for the patients, where they might receive lower quality care and eventually just be frustrated with the care that they're missing out on. Can we put a system in place to collect and use that data effectively so that the front office staff can more efficiently schedule those high-risk individuals so that they don't overlap? This can raise satisfaction, productivity, as well as quality for every patient involved, not just the high-risk clients.
Yeah, and so even outside of a physical therapy environment, if we're looking at a primary care or even a specialty environment, if we're treating patients with chronic conditions, it can really be helpful if we start taking more control over our own access, right? So we have these chronic condition patients. Eventually they may get sick. We're depending on them right now to fill our demand, right? To fill the appointment slots they have by calling into us, by scheduling online, by coming in when they feel they need to see us. We can actually take better control if we flip that around a little bit, okay? And so if we start reaching out and being a little bit more proactive, that can really help us. And what I'm talking about with this is, okay, again, Bob has diabetes, heart disease. At some point, Bob's going to get sick. If Bob gets sick and calls us when he's sick and we say, sure, Bob, we can get you in at the end of the week. We can get you in, in a week, in 2 weeks. That's an unacceptable answer to Bob. Bob's going to go to urgent care. He may go to another provider, or worse, he's going to get really bad. He's going to call an ambulance, go to the ER, and end up in the hospital. Okay. On the flip side, if we call Bob and say, hey, Bob, we haven't seen you in a while. Can we get you in 1 week, 2 weeks, 3 weeks, and you come in at this time when we have available capacity? That's a perfectly acceptable answer to Bob. Bob right then is not only, happy with the wait time, he's happy that we care about him. He's happy that we're working to schedule him, and he knows that we know he's out there and that we need to work with him. So really being proactive can not only help us fill capacity that's available down the line, it can open up more urgent care capacity that is, within the 1 to 3 days that's currently being filled by the Bobs of the world who are getting sick, who wouldn't have if we'd have managed them in a state of wellness rather than a state of sickness.
That's right. And, we mentioned this earlier, but evaluating those analytics requires asking a lot of questions about your business, about your strategy, and about your organizational goals. Do we have the data that we need? Do we have a way to visualize the data that we do have? Do we have a way to distribute the data to the right people? We've talked about this with the data-driven culture, but it is a journey and not a destination. So our goal at PDS is to meet you where you are now and help you achieve your goals using the data.
Yeah, and really when we talk about it, communication is the key. We want to make sure that everybody from executives to providers get the data that they need, that they have access to it, the high level visuals that are easy to digest and understand. But then we also need our, when they kick back the questions to finance or ops or decision support, those people need to be able to self-serve with their slice and dice and analytics as well. They need to be able to get to what they need to do to answer the questions. It needs to be fast. It needs to be reliable. They don't want to have to be telling people, yeah, give me 3, 4, 5 days to get back to you with an answer. They want to be able to do it immediately as they get the request. So being able to leverage optimized analytics is the key to communicate and get to everyone what they need. And, you talked about evaluation as well. If we're really truly data driven, as we employ these initiatives that we've been talking about, we need to be data driven in our evaluation of the effectiveness of those initiatives. So we need to continue to monitor the progress that we have. Is it going in the right direction? If it's not, what do we need to tweak in order to make it go in the right direction? And the good thing about patient access is, to know if we were successful, I need to know the answer to 2 questions. I need to know, did we see more patients? Did we see them faster? Okay, we met those, we were successful, we're doing a great job that way.
And one more thing, we both mentioned this earlier, but did the patients think we did a better job? That perception is a great thing to know as well. As the great anonymous said, we don't decide if our care is great, our patients do. So perception of how we're doing is very, very important.
Thank you for joining us. If any of you have any further questions, please feel free to submit those using the Q&A bar, and we'll be happy to answer those at this time.